Next, we'll move into connective tissue diseases, which are a broad category of autoimmune disorders characterized by inflammation of collagen and connective tissue. These include lupus, scleroderma, Sjogren's syndrome, and polymyositis, among others. Each has overlapping features which make diagnosis complex and reliant on serologic and histologic testing. So, some connective tissue diseases, which are sometimes called collagen vascular diseases, often present with very non-specific symptoms like fatigue, arthralgias, and rashes. They tend to overlap, meaning a patient can display features of multiple disorders. Histologically, we see inflammatory damage to connective tissue and blood vessels with deposition of fibrinoid material. These findings help confirm autoimmune mediated injury. Looking here, we can see our ANA testing is kind of our first test that we can utilize. This is often used as a screen for connective tissue and autoimmune diseases. It's positive in 5 to 20% of healthy individuals, and typically a titer that's 1 to 320 is clinically insignificant. We can see a positive ANA in autoimmune thyroid and even hepatic disease. And ANA is the foundation for diagnosing many disorders, as listed on this slide, in fact. And we'll discuss more about how this test is performed and how we interpret it. So now that we've introduced ANA briefly, let's define it further. ANA is the anti-nuclear antibody test, and it's foundational in diagnosing things like lupus, Sjogren's syndrome, and scleroderma. However, interpretation requires caution because many factors can influence results: genetics, infection, even certain medications. And a positive ANA isn't always diagnostic of autoimmune disease. Some healthy individuals, especially relatives of lupus patients, can have positive ANA results without symptoms. Certain medications like OCPs, oral contraceptives, procainamide, and thiazide diuretics can also produce false positives. Always interpret ANA results in the clinical context, considering both symptoms and the pretest probability of autoimmune disease. It should only be ordered ANA testing when there's a consistent clinical suspicion for autoimmune rheumatic disease. It's not appropriate as a screening tool for vague symptoms like fatigue or joint pain. Because ANA can be positive in infections, malignancy, and even healthy individuals, ordering it indiscriminately increases the likelihood of a false positive and patient anxiety. The ANA test identifies antibodies directed against components of the cell nucleus and sometimes even the cytoplasm. The most common way or method to test this is in direct immunofluorescence. And historically, animal cells like rodent tissue were used, but these were less reliable because of interspecies differences. Today, human cell lines, particularly HEP2 cells or HEP2 cells, are the preferred substrate, providing higher sensitivity for autoimmune diseases such as lupus. To perform this test, patient's serum is diluted and applied to slides containing fixed HEP2 cells. After incubation and washing, a fluorescently labeled secondary antibody is added. The slide then is read under fluorescent microscope by a trained technologist. And because interpretation relies on visual patterns, variability between technicians can occur, and this makes lab quality control really essential for accuracy. Each HEP2 slide contains multiple dots of fixed cells. The diluted serum is then placed onto these wells, incubated and washed, and the fluorescent secondary antibody binds to any patient antibodies attached to nuclear or cytoplasmic structures. Under the fluorescent microscope, characteristic patterns will start to emerge, like homogeneous, speckled, rim, nucleolar, each that provide different diagnostic clues. Reading these patterns accurately does require specialized training and experience. This slide will show how fluorescent microscopy identifies ANA patterns on HEP2 cells. We can see kind of this principle of immunofluorescence and how things are visualized. And it's important to recognize that this pattern recognition and interpretation is both an art and a science, requiring familiarity with normal versus pathologic staining. And even an experienced lab personnel can interpret a borderline case differently, which is why oftentimes these results come back as inconclusive or maybe negative when a patient is expressing all positive symptoms. So it's not the end all be all test, and it can mean that you may need to test a patient more than one time for an ANA over their disease course. An ANA result will include a titer, a pattern, and a positive or negative classification. Titers below 1 to 40 are considered negative, as up to 30% of healthy individuals can show low reactivity. Titers between 1 to 40 and 1 to 160 are low positives. They typically are not concerning unless a patient is also having symptoms that suggest disease. A titer above 1 to 320 is a strong positive and warrants further evaluation. Although prevalence data shows that even those people may, or even like that level of a result could occur in a small percentage of quote unquote healthy individuals. This is looking at these different patterns that we can see. This is a homogeneous pattern, an outline pattern, a speckled pattern, and a nuclear pattern. And it's associated with what kind of diseases you could potentially associate. For instance, homogeneous and outline patterns are associated more commonly with lupus, versus a speckled pattern often is representative of Sjogren's, or a nuclear pattern is scleroderma or polymyositis, potentially. Here you can look at kind of an overall summary of our connective tissue diseases and their autoimmune diseases, essentially, and their corresponding autoantibodies could test positive. So, for example, with lupus or SLE, we can typically see anti-dsDNA or anti-Smith antibodies, versus Sjogren's syndrome, on the other hand, is associated with anti-Ro and anti-Law antibodies. Scleroderma, on the other hand, which I don't even know if is listed directly here, often presents with anti-SC or SCL70 or anti-centromere antibodies over here. Polymyositis or dermatomyositis involves our anti-Jo1, and recognizing all these different antibody patterns and relationships is essential for interpreting these large serology patterns and large serology lab tests. Looking here, you can kind of see the visual association or reinforcement between these patterns. So you can see kind of these different nucleolar, rim, speckled, or homogeneous, as well as some of these different proteins, these nucleolar proteins, dsDNA, nucleosomes, like where you would potentially find them. It is also important to note that lab results are only a snapshot in time, and they have to be interpreted alongside clinical findings. When we come back, we're going to look more intently at lupus as a condition.